Hi again, everyone. It's Dave DeBronkart coming to you from outside Boston. I'm here to introduce again our next patient presentation in this series. It's a subject that's sobering but important and ultimately inspiring. And the question is, how can we help these people deal with COVID-19? As you may have heard, just last month, Dr. Anthony Fauci said that we are in for a whole lot of hurt with COVID-19. He's the head of infectious disease for the United States. But if you look at the statistics from Europe and Scandinavia and everywhere, it is not good. The boxed area is what's happened since he said that 3 weeks ago. We now know, though, that it's not just the death and the overwhelmed hospitals, which are bad enough, but we now know that some patients aren't getting better. And we have one of them here to speak with you in this session today. They're called long haul or long COVID patients or long haulers. At DevDays in Amsterdam just a year ago this week, we had our first patient innovation track. We also heard from Kate and Christina Sheridan with a remarkable story of a medical miracle accomplished through data. Kate was in 8th grade. She was a star student and athlete. I won't repeat the whole story here, but she was incapacitated by a bad case of Lyme disease. 30 doctors couldn't figure it out. The parents took the stack of printouts of PDFs. That's what that pile of paper is in the photo there. And transcribed it into Excel so they could do their own analysis. And when they did it, they realized there were 26 symptoms. This has so much in common with the talk you're about to hear. 26 symptoms the doctors weren't tracking. They added those in and created their own dashboard. And ultimately, they figured something out, and the girl got better. She went on to become this young woman who has graduated now from Oxford as a grad student. Our speaker today is from the COVID-19 support group on the Body Politic website. As you listen to her, listen to what it's like to try to get care when your hospital is overwhelmed. Listen to how patients have been banding together without help, gathering data and analyzing it, and even coming up with an important finding 6 months before academic medicine caught up. How can we help with their data needs? This is yet another headline about them just from Business Week last week. We are so privileged to have with us today a pioneer of patient-led research in this community. Please welcome Hannah Wei.
Hi, my name is Hannah, and I'm a survivor of COVID-19. I'm also a technologist and a researcher on the only patient-led research team for COVID-19 that's investigating long-term symptoms and its effects on the patient's quality of life. In our community, patients are suffering from months of non-recovery relapses and new symptoms after contracting the virus. They're often left without resources and unable to return to their previous lives. We call this phenomenon long COVID. Last week, Dr. Anthony Fauci stated that long COVID accounts for 25 to 35% of all COVID patients. That's equal to 14 million to 19 million people worldwide suffering from post-acute COVID symptoms. This is not a small number. So, why did it take 9 months into the pandemic for public health to acknowledge that patients are still struggling to recover? And what does this say about the way we've been treating patient data? While scientists grapple with the lack of complete data to do research and healthcare symptoms are struggling to keep up, long COVID patients have known from the beginning why our data has been unaccounted for. Today, I want to talk to you about the danger of information silos. These are silos between patients, the medical community, and a technology that talks to both. To illustrate this, I want to take you on a personal journey of my experience struggling with COVID-19. Before March 11, I was a healthy 30-year-old. I worked in product design and I had no pre-existing conditions. I was athletic. 5 days after an international flight home to self-isolate, I thought I would be safe. I felt sick. I remember my lungs hurting more and more every day, and then I started coughing up blood. It was quite traumatizing. I called the COVID hotline, but the doctor I spoke to discouraged me from seeking care or testing. She believed I was too young to have caught COVID, and she thought it was the flu. Another 5 nights later, I was drowning in my breathing. My heart rate shot up, and if I laid down, my blood oxygen plummeted. It was unlike a flu. For the first time in my life, I feared that I wouldn't wake up alive. So I also feared that I would be turned away at the hospital. So I called the telemedicine again. This time, it took 3 hours on the line to talk to two nurses. Every time I struggled through gasping my symptoms to explain from the very beginning, talking to another provider. Thankfully, they confirmed that I qualify for a PCR test based on my symptoms and travel history and recommended me to an emergency department. So at 4 in the morning, I dragged myself to the hospital. At the ER, I was triaged again, and this time the doctor decided I didn't deserve a test because, well, I was still standing and breathing and test supplies are low. Well, I was disappointed, but I understood. So I asked for a chest scan. At least tell me what's wrong with me. After the scan, I was left to wait in a quarantine hallway for the doctor to deliver my results. The morning had passed, and by noon, I was still waiting. I was trying not to faint from a lack of sleep and water, and yet the doctor was nowhere to be found, and more patients kept pouring in. It was clear that I was simply too low on the priority list, so I asked if the nurses could provide results over the phone. They said no, they don't do that. Finally, after 9 hours in the ER, I gave up and left empty handed. Weeks passed and there was no follow up. It was as if I arrived with a bruise, not an infectious disease. That left an impression on me. I felt dismissed and unseen, and I stayed home. I didn't try to seek care until about a month later when I visited an urgent care clinic for ongoing chest pain. The doctor there was able to find my results finally from that night, and the doctor's note said that they found the lower lobes of my lungs were in fact infected, consistent with COVID-19. I was a suspected case. That news came a month too late. When a doctor administered a PCR test that day, I had tested negative. Testing negative, though, doesn't mean that the damage went away. For months, I suffered from unexplained symptoms of rashes, shortness of breath, allergies. I'd never had allergies before, headaches, and crushing fatigue. It wasn't until mid August that I stopped coughing daily. That negative test result sealed my fate in getting further care. It barred me from the few post COVID clinics available only to patients with a positive test result. And I was disqualified from COVID studies that can potentially help understand this disease. Doctors would not take my symptoms seriously. They've never seen long COVID cases in journals, and much less from non hospitalized patients without a positive test result. It was a vicious cycle of neglect and dismissal. But my case is not unique. Thousands of patients like me have fallen through the cracks of healthcare, if not hundreds and thousands and millions. When my patient-led research team conducted a survey back in April, 640 patients in our long COVID community said that they were denied testing, and that was about 48% of us who have no access to a test. At the same time, we found that the prevalence of 60 symptoms were statistically consistent across the board, regardless of test results. The major difference, however, was the timing of the test. Those who tested positive were reported to have tested 6 days earlier on average, and on day 10 of their infection. We are not counting out the cases. Often, when long COVID patients call into their physicians, we only have subjective accounts to go by. Some patients have been told that their symptoms are simply anxiety. Patients were prescribed treatments like cognitive behavioral therapy, which frankly does not help when you have ongoing multi organ inflammation. So, when we are uncounted, dismissed, and not monitored, our care providers lack the data, the research, and the best practices to help us, even if they wanted to, because in the end, we're not in the literature. So information silos are unsustainable. No one is as invested in solving this puzzle of long COVID as the patients who are struggling through it ourselves. This is how COVID-19 patient-led movement began. Frustrated patients poured into support groups on social media. We found validation through similar unexplained symptoms and ongoing relapses. We shared resources. I shared this spreadsheet originally helped me regurgitate my symptoms. In the end, it helped another patient get triaged quickly when she was unable to form coherent sentences, and I was quite proud of that. Others created exhaustive symptom lists, compiled Q&A from physicians at clinics they don't have access to, and collectively disseminated research. We did quite a lot. Body Politic is one such community that formed around long COVID patients and has been growing on Slack since April. And today, our community has about 9,000 people. On Facebook, there are other long COVID communities across the world with over 100,000 people. And this is just the English speaking patients, too, that we're connected to. Across the world, many folks who are not recovering from COVID are joining support groups every single day. My patient-led research team organically came together in this community with our burning questions and large body of patient data and research expertise. And together, we assembled a report that was published in May. This sparked big interest. The report, which you can access on our website, became the first of many hurdles to get long COVID recognized in the medical community. In the summer months, we were cited in the COVID guidelines for primary care physicians in the British Medical Journal. We appeared on panel with the WHO and consulted with other public health organizations. Today, we have over 20 researchers and advisors on our team. We are all long COVID patients. Just last week, a new preprint from Mount Sinai's Hospital's COVID clinic confirmed our findings in May. And that was around the consistent symptoms across patients who were tested negative and positive. So, what does this prove other than that patients were right the whole time, but were not listened to? Well, it proves that we cannot effectively minimize the damage of this pandemic by working in information silos. Healthcare professionals, scientists, technologists must believe in patients' experiences and invite them to the table when defining this disease, when tracking its data, and when designing the treatments and policies. Patients are not merely subjects. We are also a force of innovation. As much as long COVID is a confusing phenomenon, it is also, in my opinion, an exciting space to move forward in making healthcare more equitable. People often forget that before we are known as long COVID patients, some of us are also scientists, medical professionals, public policy specialists, technologists, designers, business owners, what have you. We are well equipped to collaborate. So let's talk about how can healthcare IT collaborate with us. Well, if you're building a system that collects data around COVID patients, consult the patients. So at the very least, you can make sure that you are collecting the kinds of data that don't leave patients stranded from care. Here's an example. As patients, we find that many online questionnaires around COVID don't ask the right questions about our symptoms. A system or app reporting data only around fever and shortness of breath may unintentionally dismiss a patient who may be experiencing blood clots. You probably don't know the term COVID toes, but here's what that looks like. Because COVID is such a multi-organ disease, patients can tell you exactly what that looks and feels like in our bodies and how communicate it in a way that other patients may recognize and get care in a more timely, effective way. On the other hand, people who are systemically dismissed might find themselves in the hospital weeks later with a seizure, kidney pain, or cardiac arrest in the case of blood clots. This is confusing and costly. These are a lot of the stories that we hear in the community, unfortunately. And so we must do better for our patients and healthcare workers. I want to end this talk with hope. Data oversight is fixable if we break the silos between the experts and the wisdom of collective patients. So let patients help. I want you, the ones building these critical COVID apps, dashboards, and healthcare infrastructure, to reach out to our patient communities and connect with us. This is an innovative and urgent space where we should be asking each other the hard questions and redefining what equitable access to healthcare looks like. I believe that together we can make data suck a little less and help people with long COVID and perhaps other overlooked chronic illnesses too. Thank you.